Good evening, everybody. It's really lovely to see such a nice turnout here this evening, and I'd like to welcome you to this inaugural lecture. I have to first of all do some housekeeping. So we are not expecting any fire drill or alarms today. In the unlikely event of an alarm being activated, make your way to an assembly point. Please do not re-enter the building until instructed to do so by a person of authority, a fire warden or security. And the exits are marked with the green signs. I'm Kenda Crozier. I'm the head of the School of Nursing and Midwifery here at Queen's, and I'm very, very pleased to be able to introduce this inaugural professorial lecture for Professor Bernie Carter, who is an honorary professor here in the School of Nursing and Midwifery at Queen's. And she is a professor of children's nursing at Edge Hill University. Bernie is an RCN fellow, and that fellowship was awarded for her work on children's pain. She's also president of the Association of British Paediatric Nurses, which is the oldest children's nursing organisation in the world. Bernie undertook her training in an integrated programme, which was joint RSCN and SRN. So that's a registered sick children's nurse and a state registered nurse. She trained at Great Ormond Street and at Addenbrooke's Hospital. And I was saying to her earlier on about the lovely uniforms that the Great Ormond Street nurses used to come to Addenbrooke's with. I trained in Addenbrooke's, and we all felt very underdressed in the regulation J cloth. But they did rustle a lot as they walked with all that starch. Her undergraduate degree in nursing studies and her PhD on preterm babies' pain are both from Manchester Metropolitan University. And you have some colleagues here who are also from Manchester. Her research is child-centred and focuses on children whose lives are disrupted by pain, illness, disability, and complex health care needs and disadvantage. And this work is primarily qualitative, participatory, narrative, creative, and arts-based, which is a wonderful combination. And we spoke earlier today about the joys and pains of being a qualitative researcher. And so stories are key to her work and how she understands children's lives. She works closely with experts from different academic disciplines and professional practices. And this includes illustration, dance, drama, and animation, which sounds just fabulous. She absolutely believes that research can be fun and is good for the soul. It's also quite trying at times, but her current research portfolio is diverse, including studies on children's breakthrough pain, sleep, and children with epilepsy, building medicines resources for parents of neonates, pain and somatic practices, teaching children to swallow tablets, holding children for procedures, and falls in children with cerebral palsy. This is all delicate work in a very important area. And we are very, very proud to have you as an honorary professor here. And I saw the children and young people's team here being very gathered around you very closely today, which is great to see. So I'd also like to say thank you to the patient and carers representatives who are here tonight, as well as all of the staff, students, and colleagues from clinical practice. And I'd like to welcome Bernie to give her address. Thank you.
Thank you. So it is an absolute honour and a delight to be here tonight. My lovely welcoming colleagues in children and young people's nursing have been telling me how excited they are about tonight, and I've been going like, oh. So we're going to see how excited they are at the end of the lecture. Hopefully they'll still want me to visit. So pretty much everything that I've done in children's nursing has been a surprise to me. Being here is a surprise to me. It's not anything that I'd ever expected to have done, or a pathway that I'd have expected to take. So what I want to do is tell you some of the stories that I've encountered during my career, and also to share some of the stories that children have told. And I'll talk a little bit about stories in a bit. So here we go. And I can only stand here and talk as a researcher, because parents and children and young people and my colleagues have been generous enough to share their experience, their expertise with me. Otherwise, I wouldn't have anything to talk about. So thank you to them. So meet two of the children, drawings from children. And one of the things that I'm passionate about is children's pain. And this is what children draw if you ask them to draw what pain looks like. And we'll talk a bit more about that. So acknowledgements. If you look at the top, this is a picture of a community tower building project that happens in Spain. It's traditional, and they take the smallest, lightest child within the community, and they take them, all the child crawls up, all of the adults to the top, and they balance there. And in lots of ways, I feel that image, although I'm not a teeny tiny child, I'm sort of standing on the shoulders of many other people that are actually supporting my career and the opportunities that I can create for other people. I have got a list of people that I could mention, but it will mean that I just talk for the whole 60 minutes about people that have helped me. So everybody that's helped me, particularly the children, the young people and the families who've often helped at times that are really difficult for them. My family and friends who've had to listen to me through the joys and the more difficult parts. All of the people that have taught me, from when I was tiny being taught by nuns to people that continue to teach me today, lecturers, my supervisors from my PhDs and my other my clinical colleagues. I'm still very closely linked with clinical colleagues, co-researchers, all of my research students, and I'm delighted. I'm going to name drop Heidi Chen, who's one of my PhD students, and she's come to listen to my lecture tonight from England. I think she actually wanted to see Belfast, but there you go. Dancers, illustrators and writers, as I've got older and maybe a bit more secure in my career and qualitative research has become a bit more accepted, I've had the opportunity to work with lots of people that I would have never imagined that I would have been able to work with. And I've learned a ton from them, not just about children, but also about nursing and who I am and about research. Huge thank you to Winnie the Pooh and Dr. Zeus, and a call out for Doris Corkin for making that phone call and telling me about 2 months after or about a year after I'd kind of retired from doing a lot of things, that coming to Belfast would be good. And she's right. So I've been a lifelong reader. One of the things when you're reading books, unless you're reading a really postmodern book, which perhaps starts at the end and then you move variously through, I'm going to take you through a few chapters of my life. But as in all maybe good or not so good books, there's a preface. So here we go. Stories don't always start at the beginning. In fact, many of the stories that you listen to in practice or in research start somewhere that isn't even the beginning in the head of the person that's telling the story. And stories have a strange habit of wandering off in really strange directions. And what we need to do is follow some of those directions. And just in case I wander off track, this is my get out of jail free clause, because I have no idea where lectures are going to go. So off we go. So here we are. This is a picture of the Milky Way galaxy. I have checked with my partner, who's much brighter than me about astronomy. And this is a picture of a part of the Milky Way galaxy taken from Earth. And NASA says it is as well. So that's good enough for me. So I'm starting with an image that I want you to take with you when you go home tonight, rather than all the photographs that I've had taken of me. This isn't perhaps an image that you'd expect to see at the beginning of a lecture done by a children's nurse who's got absolutely about that much knowledge of astronomy and everything else that is to do with studying galaxies. But as far as we know, unless you believe in Star Trek, Star Wars and science fiction, and my heart beats fast for science fiction, We are the only planet in this galaxy that has beings on it, us, who make meaning of their world consciously. Now that's quite something. And I can say that because Brian Cox, who knows a lot more about astronomy than I do, said so. So where this takes us is to the fact that I think of my life with stories and our life with stories as being something like being part of a galaxy of stories. I would argue that for the most part, we're surrounded by as many stories as there are stars within the Milky Way. There are loads of them. The stories that we hear, the stories that we listen to, the stories that are shared with us, and these aren't stories that are written down, they're not necessarily terribly competent stories, but we make meaning of our world through the stories that we tell. You'll go home from this lecture tonight with a story like, it was awful, or I liked that bit when she stopped, or whatever it will be. So those sorts of stories are the things that help us understand things, help us make connections, help us think about the world in a different way. When I think about practice and research, I do think about this notion of stories that we're either aware of or we're not aware of. Some of the stories that we come across are bright stars that we listen to, we hear, and they kind of like flash in our eyes. Not all stories are good. So there are quite a lot of stories in the world at the moment that we kind of want to not listen to. There are stories that are perhaps the dimmer ones that we're not particularly aware of, but they're just as important and ones that we need to take attention to. So all stories are important to the person that's telling them. So I think that we need to think about stories more as being something that's more important than perhaps they're given credit for. When I was talking to Michael, I'll name drop Michael, he said one of the things that you like as a picture is to get to know my family. So I will do my best, and I might choke up a little bit, but here we go. So top left picture is me and my mum and dad. I think that was Butlins, which was kind of pretty classy in those days for us. We didn't go away very often. I have a lifelong love affair with bicycles, and there's bicycles in quite a lot of photographs here. Mum and dad didn't have the opportunity to stay in school, to stay in education, to get a lot of the opportunities that I want. They saw themselves as not very well educated people, but they were blindingly courageous, brilliantly kind, and super supportive of their 4 daughters being given the opportunities that they didn't have. They never pushed us to be something. They asked us to try hard. They were slightly surprised when I decided that I might become a nurse, and I was slightly surprised as well. But they were together. They're kind of like my model of kind of like perfect people, perfect parents. They absolutely adored each other, and that was a picture of them in their at their golden wedding anniversary. Mum's never made it to one of my professorial lectures. Dad did, and just spent the whole time talking to my the people that were employing me, saying, she's really not that bright, you know. and other kind of encouraging dad things. So he was fantastic, but kind of intensely proud. The other person that's never been to any one of my lectures and didn't know that I went into education is my older sister, Angela, who did voluntary service overseas in Africa. She then went back out because after she'd completed her voluntary service and worked for the government doing nutrition work, and used to cycle into villages supporting people to improve nutrition. And then there's my little sisters, Bridget and Claire, and I'll show you another picture of them. My family is the love of my life, and that's the 2 of us. I always remember looking after them when I was little. Angela was 8 years older than me, so she was kind of super grown up. Picture at the bottom is of the 3 of us in a coffee shop where we decided we better take a picture in case anybody died before we actually got back together again. Bridget is on the left. Her excuse for not being here tonight is because she's in New Zealand. It's a weak excuse. Claire's not so well at the moment, but she sends her love. And then at one point, when I was trying to finish my PhD, I fell in love with a really lovely chap. This is a picture of him a few years ago. He's a bit grey haired over there now, but he's been with me every step of the kind of like a lot of the hard yards. Showing a map here suggests that I had a clue about what I was doing as a children's nurse, that I'd planned a career, that I'd worked out what A-levels I was going to be doing, all of that sort of stuff. And then after that, I had a grand plan for how I was going to become a professor. Not a clue. I'm basically in the middle of the woods, stumbling around, trying to find my way through. Probably the one thing that's helped me the most is the fact that I read all the time. Literally, I've never gone a day, I don't think, where I've not read something that is fiction or anything. I read work stuff, but I also read fiction. Here I'm reading something about a Bry Nylon advert, which shows how long ago that was. And my parents, much as they loved me, put me on the top of the table, waiting for me to presumably fall off. But there you go. The picture of me there is slightly terrifying in a nurse's uniform, probably when I was about 9. I was slightly disgruntled by it because I would have preferred to have had a mechanic's set of overalls so that I could help Dad mend the car. I'm sort of modelling a fairly scary matron at that stage, but there you go. And I trained at Great Ormond Street, which I'll be telling you about in a second. I hadn't actually heard of Great Ormond Street before I'd read Mallory Towers. And the last term Mallory Towers, Mary Lou, who's the very quiet, good girl, goes off to train to be a children's nurse at Great Ormond Street. I didn't actually tell them that when I went for my interview, but basically you can get careers advice in really strange places. So I asked my dad, do you know where Great Ormond Street is? And he worked about 10 minutes walk away from it, and he said yes. So that's how I ended up there. No plan at all. This was the October 76 set. Still in touch with a few people. We were lovely. We were such a lovely girl. We were told how lovely and how wonderful we were, and how privileged we were. And it was a privilege, and I still think it is a privilege to train to be a children's nurse. I did the combined or integrated training, which at the end of 3 years, 8 months, I came out with my SRN, RSC, and I still think of myself as that. I know I'm not. I know I'm an RN child. Doesn't have quite the same ring to me. I approached that knowing that I had to do a year of adults, thinking, well, that will go quite quickly. And then I'll get back to what I really want to do, which was children's nursing. But I actually loved it, and I was challenged by it. And I'm so glad that I did that adult training, because it meant that I had some idea of what parents and grandparents had when they were talking about, I don't know, COPD or something like that, things that you didn't see so much or didn't see at all in children. We progressed from a lot of starch to ridiculously complicated starch with our hats, which took ages. And I used to be the person that made up quite a lot of people's hats. They got rid of the hats after the person that did the gophering iron on the ringlets got too old to do that. So the reason why changes advance, you know, somebody became too elderly to wield the iron. And in many ways, staffing was the perfect job because I was close to the children. I was developing competence. I absolutely loved it. And in a way, it came as a surprise to me that I ever left being a staff nurse. But there seems to be a pressure within a lot of careers that you should progress, otherwise you're standing still. And I don't always agree. I don't agree with that. But the things that I learned as a student and as a staff nurse in the staffing jobs that I did, and then as a sister, have been fundamental to everything that I've done as a researcher. Without that kind of understanding, I don't think I could have done research in any way nearly the same. When I was doing slides, I was trying to work how long I'd been in children's nursing. I kept going, oh, 30 years, daft, 40 years, no, 50 years, can't possibly be 50 years. I'm about 15, 16, 17 months off from 50 years in children's nursing, which is almost completely terrifying to me because I still feel about 50 or something, I suppose. But there's so much going on. There's so many interesting things that are happening. There's so much to learn that every time I think I'm sort of topped up with knowledge, something else comes up or somebody asks me a question. So I'm going to Dr. Zeus, who does some really great career advice. If you want to read the places you'll go, this is the more that you'll, I can read with my eyes shut quote. But the more that you read, the more things that you'll know, the more that you learn, the more places you'll go. And I've never really gone terribly far. If you look at where I've been, I've done a bit of London and a bit of Northwest and occasionally popped off somewhere else to do things. But you can go places without necessarily having to sort of move terribly far from home base sort of thing. And the reason I'm still involved and active and trying to still be a researcher is that there's so much more room for change. What we want to do is to do really brilliant practice for children and families. And the other thing is that when you look back over 50 years of change, technology has changed. We didn't have syringe pumps when I first started for babies because they were just, the pressure was just too high. Research was almost invisible. People that did research weren't people like us. When people talked about research, they talked about it in such a complicated manner that how anybody ever survived to become a researcher was beyond me. Lots of things in practice have changed and lots of opportunities have changed. And for a little bit, I've been one of the people that's been arguing that there should be better careers for people coming behind me in research and in practice and in clinical academic practice, because they weren't there for me. And so kind of like a bit like, it didn't happen for me, but let's make change for other people. So again, I could talk a lot about what sort of things I've done on the way to here, but broadly, I spent really happy years in clinical practice doing children's intensive care, children's gastro, neonatal intensive care. And I was the most annoying person that anybody could ever employ or work with, because I was always asking what and why. Why are we doing it that way? What's going on? Can we do it better? And in the end, at that stage, somebody said, well, go off and find out yourself. But there weren't really any places to go. The training that I did was training. I think it was brilliant, but it was training. We didn't do anything massively academic. I found it quite academically easy coming from A levels. And then I looked around and found a nursing degree course because it was the only thing that I could find that was going to kind of start to give me some of the answers. At that stage, there weren't very many children's nursing courses that you could go and do to develop your practice. So you couldn't go and be a more expert children's intensive care nurse. So I did the BSc at Nursing Studies, and my understanding of what I learned was usually about 2 semesters behind the time that they taught it to me. So kind of like the policy bit clicked about a year after they'd taught me the policy module. So I'm a really slow absorber of knowledge, but once I've got it, I kind of keep it. I really enjoyed that. And at that stage, I was beginning to sort of make the shift from thinking of myself staying within practice and moving somewhere else. And that felt like one of the guiltiest moves that I've ever made. I did move in to become a nurse tutor, and then got an offer after I'd completed my degree to go and do a PhD by my boss at the university, who said he needed somebody to do a PhD and would I do it? Had no idea what a PhD was, but I just said yes because he was my boss. And then that started my sort of 3 and a bit, 4 years of doing a PhD part-time. I was pressured to finish quickly, so I learned how to write quite fast, and that was interesting. I was about the only person that I knew that was doing a PhD in nursing. I didn't know anybody else that was doing a PhD in children's nursing. It was really, really lonely. So if you've got a community, stick with that. So I got my PhD in 1995, and then there was encouragement when I'd moved to a different job to apply for a professorship. I didn't think I was ready for it. My boss, who said go for it, didn't think I was ready for it. And then I got it, and I wasn't ready for it. And I've been playing catch up pretty much ever since, sort of thing. So so that was both awesome and slightly terrifying. It's like, I don't know, driving the world's scariest highway when you've only just passed your test. In terms of other standout things, I was really fortunate to be made a fellow of the Royal College of Nursing, which was to do with children's pain. And colleagues that knew about my work from Australia and New Zealand invited me at different times to become clinical professor, so like an honorary professor out there. So I had a few trips out to Tasmania and Auckland, and boy, do they work you hard there. Tell you, Belfast's a treat compared to that. I mean, the airfare is bigger, but there you go. You just wind it up now. What's kept me busy? Loads and loads and loads of things. I am like like the toddler that's got, there's a box there, I'm going to explore the box, and then there's another box over there, so you go and explore that. I'm kind of a methods glitter ball girl, like, it's pretty, I want to try it. This one's really lovely, I want to try that. So when I first started, doing qualitative research was really strange, and I got ribbed, ridiculed, all sorts of different things. People go like, are you doing what? You're watching a baby? Yes. Why? To see what it does. So when I then started interviewing children, people typically didn't think that children could be interviewed, that they just weren't particularly competent. If you use the right tools, you can engage with very young children very, very effectively. So, and I'm not frightened of using new methods. So kind of did early adopter of things like collage, of photo illustration, narrative, a whole lot of different things. But I am really cautious that I fall in love with something and then I date it for a while to make sure that it's going to be good, and then would think about using it within practice, and all the time with using parents and children as experts to tell me whether or not they think it's a good idea. Otherwise, you just fall in love with stuff. I've done tons of supervision, mostly because there weren't very many people around that had PhDs back in sort of 1996 time. So at the moment, I am now up to 32 completed PhD students who've all gone on to do really amazing things. Some of them are now sort of top of the game, nothing to do with me, because kind of like that they were wonderful people to start with. And I've examined 73 PhDs of various sorts, all of whom have been brilliant. I got involved with writing books. My first book came about when my boss in a different place asked me, would you like to edit a book? As I was going on holiday. So I said, yes. And when I came back, she'd actually got me sort of involved in editing books. So I've done books on children's nursing and pain, lots of writing of papers. Writing papers either makes me very happy or makes me cry, and sometimes both at the same time. I got slightly landed with editing the Journal of Child's Healthcare, did that for 23 years, and it went from actually people sending in copies of the paper that you then put in envelopes and sent out to people, and then it came back that way, to turning it into a fully digitalized sort of system with Sage. I've been involved with the Association of British Paediatric Nurses, partly through the journal, because the Journal of Child Healthcare is their journal. And I'm now president, which means I have a big badge, which is really exciting. So that's been wonderful. And I'm part of that, not because I like the big badge, but it gives you a bit more of a voice, that if you want to advocate about children, you can say that you're part of the association. So that's quite important. So talking about stories now, we all tell stories. A lot of the writing about narrative and stories that inspires me doesn't necessarily come from academics that are writing about narrative and stories, because sometimes that's quite theoretical, sometimes it's quite worthy. So because I read a lot, I also read what people who write a lot state about stories. So Ursula Le Guin is a pretty brilliant science fiction writer, very clever woman, writing beautiful stories. And she says there have been great societies that didn't use the wheel, but there have been no societies that didn't tell stories. It's fundamental to who we are as human beings. And I don't think you necessarily need to be able to speak to be able to tell a story. I've seen neonates tell me a story. I've seen children who are completely non-verbal, tell stories through movement and through response to things. And Terry Pratchett, whose hat I seem to have chopped off, completely the other end of the scale, completely wacky stories for anybody that's read them. But he says people think that stories are shaped by people. In fact, it's the other way around. So the stories we hear change who we are and how we think about yourself. So for anybody that's not a PhD student, the next slide makes sense. Anybody that's a PhD student and using narrative, you have to have a slightly more sophisticated definition of stories in your PhD. So when I started looking at stories and thinking about the fact that I might interview a child or interview a parent or interview a nurse or interview, I don't know, I've interviewed a contortionist, would you believe? But there you go. How do I know that what they're telling me isn't just an answer to a question and it is a story? And does it make a difference? And when you look at the literature, it's huge and it's complicated, like everything is about methods and methodologies and things. And the academic literature will tell you lots of different things. But I think of ducks when I think of stories. So mostly stories are like ducks. So if it looks like a duck, it quacks like a duck, and it walks like a duck, it's a duck. If it feels like a story, seems to be a story, and it is a story, it's a story. And then you can work out what you're doing. So that's where I say that you can't say stories are like ducks as your definition in your PhD thesis. The thing is that not all stories are alike. So in the same way that possibly that's a mallard, there are lots of different ducks. So the sorts of stories that the sorts of approach to stories that you might use if you're involved in narrative research are different. So the chap on the right is Art Frank, who's written a lot of books. I invited him to come up to university, to Manchester, to UCLan when I was there, because I saw he was in Bournemouth doing a paid lecture there. They'd paid him to come over from Canada. So I said, if I give you the train fare up to Lancashire, will you come and do a session for us? And he said, yes, if you take me for a walk. So we've been walking and talking pretty much ever since. So that's probably about 20 years ago. So in terms of the person that I follow, a little bit guru-ish, Art Frank is the guy. And basically we have long chats. John helps me with some of the more esoteric components of his chats because he's also does a lot of work on literature. And he gets me heavily involved in thinking about King Lear in a different way, which is not where my strengths lie. Why do we think stories are important? Well, I think they're important because of the landscape that we live in. The stories that people tell us are stories of their experience. Art Frank says that stories act to make life social. And one of the things that we lose when we're ill, adult or child, is that sense of being part of a social world, part of a connected world. Stories cross time and place. If a child tells you a story, it will be, well, it was a long time ago and it was yesterday, or it's going to be a long time in the future and it's tomorrow sort of thing. But they do, like I said, help us create meaning. And in one of my more, I don't know, this was an editorial somebody asked me to write. I think that stories are important for nurses because they can reach across to people whose story is reaching out to us. So while we're measuring things and charting things and doing all of the things that we need to do in practice or in research with children, we need to be attending to the presence that they're giving us in the story so that we can reach back to be a nursing presence in their stories. This is Crow and Weasel is a traditional story written to support Native American children learning about their culture and their stories. Beautifully illustrated, and Barry Lopez does a fantastic job of telling about these two central characters. And they say the stories people tell have a way of taking care of them. If stories come to you, care for them and learn to give them away when they're needed. Sometimes a person needs a story more than food to stay alive. And sometimes children and adults, parents, just need somebody to listen to the story that they tell to give them the courage to go on with the next day, minute, hour, decade of their lives. So who tells stories to me, to us? Pretty much anybody. I was writing a list and then I just put that and everybody at the end, because stories come to you in all sorts of different ways and in all sorts of different places. I'm really proud that I've been able to collect, sounds like you're sort of the child snatcher from some sort of film. Chitty Chitty Bang Bang. Yeah, there you go. But children will tell you stories. You just have to be prepared to listen to them and to realize that it is something that's of importance. We can learn from all sorts of people. And one of the things that's been a joy to me is, having supervised several trillion PhD students, I have learned so much from the stories that they've told me about their experience in practice or collecting research data and so on. I can wax lyrical about stories, but there are some really malignant, malevolent, difficult stories that are out there. Stories are not all good. There are some difficult stories to listen to, sort of propaganda stories. But even if it's a story that you would see as a good value story, they're always situated in the context, they're always situated in the history of the time. So children can only tell stories based on their ability to be able to tell stories. Marginalized groups, marginalized women can only tell the story that they think they're allowed to tell to the person who is listening to them. So all stories are framed by kind of like micro and macro politics. Some storytellers, children, women, marginalized groups, all sorts of different people, can be perceived as untrustworthy. You know, we're telling fibs, they're telling lies, they're making it up, they're fabricating things. And if you start to think that about one group of people, you should be thinking the same thing about everybody else. We're all capable of telling unreliable stories at some point in time, but you tell them for a good reason. And stories can be hard to hear, they can be ignored and dismissed. And for a long time, I think within some areas of practice, we've not always listened as hard as we could. And the thing that worries me a little bit about some researchers is they like to collect the really difficult, gruesome, terrible story and then tell that at a conference as if that's typical of everything that's happening. And kind of think they're a little bit like horror magnets. Let's just go out and get the headline news rather than a much more sophisticated approach. In terms of triggering stories, there's a lot going on with quite hard to ask a child or somebody who's not feeling very confident about sharing a story to just do it sort of like face to face or even remotely. So I use quite a lot of drawings, and use photographs, we use drama, we use collage videos, all sorts of different things, activity booklets, so that the gaze of the researcher is not directly on the gaze of, you know, the child. They're not having to sort of look you straight in the eye. And puppets, toys, all sorts of different things. It's a great way of spending research money. You can go out and just get loads of glitter and pencils. And this is something from The Little Prince by Antoine Saint-Exupéry, who shows this picture that says that quite often we see things differently to the way that children see them. So here, this is possibly a picture of a hat, or it's a picture of a snake that has swallowed an elephant. So one of the things that we want to do is think, is the thing that we're seeing, interpreting, looking at, perceiving, what it is it the same as the person, the thing that the person is trying to explain to us? So I'm quite visual, and I can't imagine a snake actually swallowing an elephant, but there you go. We're running quickly through some of the things, selections of things that I've looked at. Stories of being cared for at home, where children said, so they sort of go top left round. Children's community nurses are absolutely fabulous. These were the Diana nurses a long time back, absolutely fabulous, but nowhere near as good as mum and dad. And that's their benchmark. If you could be as good as mum and dad, then you're great. The picture of children growing up with a chronic illness, this is one of the ones that I did when I was out in New Zealand. And the children, we gave the children disposable cameras, they took the pictures, and then they picked the pictures and then talked about what it was like to grow up with a chronic illness. And the little chap doing his wheelie at the top on his BMX bike also had a whole lot of pictures of factor VIII medication. He was a haemophiliac boy, and his mum said he just likes anything that sort of frightens the bewotsits out of me. But he projected, as do most children with chronic illness, themselves as being absolutely normal, but with. So it would have been much easier, and there were great pictures of kind of like tourniquets and drugs and things to focus my story around that. But he was much more interested in telling me about the tricks he could do. We've done some great work working with children in wheelchairs, where we had able-bodied and children with disabilities doing sports in wheelchairs, so all sorts of different things. I'm not going to talk masses about these things, but these are some of these things are things that wouldn't have been seen to be worth investigating, certainly not really worth investigating qualitatively until you start to do that work and the stories start to be told. A lot of the work that I've done is on children's pain, or some of the work that I've done is on children's pain. This is a picture that a child drew for me a long time ago, but it's kind of you kind of know that child has suffered and is suffering. And again, I'll talk a little bit more about why sometimes pictures can give you insight into the stories that children will tell. Art Frank says that trouble is central to stories, that unless you've got some sort of trouble, a story isn't really tellable, because otherwise something happened. Yeah. You want to say, like, oh, I was going to the bus stop and then I tripped over my shoelace and I fell and I didn't think I was going to get to the bus. Just like I walked to the bus stop is not a very interesting story. So he's saying that the thing that is crucial to stories to be told and for us to listen to is that sense of trouble, that sense of uncertainty that's there, because that's the thing that makes stories tellable. So for me, in the stories that children tell me about pain, trouble is actually that child's pain. It's often the parent not knowing what to do, as expert as parents are, and they are real experts when it comes to children. Trouble is the challenge of communicating pain, and trouble is also for professionals not always knowing what to do about pain, because however experienced, however expert we are, we sometimes get to the point where we're not quite sure. So I'm going to talk a little bit and run through some of the myths that were evident when I first started, and that I think I was talking to some neonatal nurses today and saying that the thing we need to do within practice, within research, is stay curious and ask ourselves, what are we doing today that we could be doing better? And we might look back in 5 or 10 years' time and say, why did we do it that way? Why didn't we know that sort of thing? So when I first started, there was a general assumption that babies couldn't feel pain, that even if they could feel it, they couldn't remember it, that we couldn't assess babies' pain because, well, why would you assess something if they didn't have it in the first place? And that children, even kind of like 4 and 5-year-olds, wouldn't really be expressing pain, they'd just be expressing anxiety. Now, this was kind of like a common set of beliefs within nursing that had never occurred to me until I went into nursing, because you mostly know that if a child falls over, they cry. You know that babies cry if they get colic. Anybody that's kind of had a colicky baby knows that they're probably just distressed rather than in pain. Not true. And the book that I spent part of my first salary on in the days when nurses training got salaries was Baby Surgery, which was the Bible that we basically kind of followed. Not a mention of pain at all. Whole book on baby surgery, not a mention of pain, not a mention of analgesia. We did a bit of comfort positioning, but that was about it. We looked after the babies as well as we knew at the time. We did as many interventions we possibly could do. And the wee baby on the left is baby from my PhD, who taught me probably more than any other baby. I spent a lot of time looking at this little one. He's 30 now, something like that. The myths about children's pain. Children are less sensitive to pain, no evidence for that. Children get used to pain. No, they don't. It gets worse for the more pain that they have. They're not very good reporters of their pain. Absolutely not true. They are accurate if we give them the right options. If a child can be distracted, if they're playing, they're not in pain. Not true. If a child says they're in pain but don't appear to be in pain, they're not in pain and we don't need to give any pain relief. Not true. And all of these things have now got evidence. Some of the bits that are bold are where I've contributed in one way or the other to the evidence in a small way. And for me, children with profound cognitive impairment don't feel as much pain as children without impairment. No evidence for this at all, none. And they've got less capacity to be able to manage pain or to understand it. And a recent one that I heard was that young people with chronic pain are not that interested in romantic relationships, probably said by somebody that is not that interested in romantic relationships. When we did the research, the young people with chronic pain were very good at romantic relationships. They just needed a bit of support. The notion that children can't talk about pain, as soon as they can start to use figurative language, they're pretty darn good. Pain is a monster I can't hide from. A 5-year-old gave the quote on the right-hand side. When I first asked her what her pain was, she was pretty much an expert in pain, and she said, I have an intense radiating pain in my upper gastric area that fluctuates between a 6 and 9 on the pain ladder. And I went, oh my goodness, you're tiny, you know. A lot of words there. She'd learned the chart talk, the professional talk that people had talked about around her. So she was a mimic. Okay, so if you take that, she's a good mimic. She didn't really understand exactly what she was saying. And I said, well, what does it make you feel like? And she said, when it's bad, it's like the sun's gone away forever and I feel bad and sad and frightened. So the treatment that you do for the upper epigastric 6 to 9 pain might be giving medication, but you won't medicate for somebody, a child that's feeling sad and frightened. You have to do something else. You have to do something much more intensely nursey. Injections don't hurt. Good myth. Not true. Injections do hurt unless you do something about them. And more recently, something that kind of like frightened me a little bit was reassuring a child by saying this won't hurt, which was one of the things I was taught to do. Well, that was considered that would reassure children. Telling a child not to worry about something will reassure them. What it tends to do is kind of like prime them for the fact that I didn't know it was going to hurt. What do you mean it's going to hurt? Where's it? Why? What have I got to worry about? So it was a bit of a backlash within sort of some of the procedural literature saying don't reassure a child, which again didn't make any sense to me. So we did a bit of work and worked out that actually you just have to be careful on what you say to reassure a child. So don't tell them not to worry, because tell them they're going to tell them something different. Myths such as nurses are great at assessing pain. We're not always that great. We're not bad, but we don't always do brilliantly. Parents are not great at assessing pain. Actually, they do pretty well. If they do anything, they underestimate a bit because it's too painful to think that your child could be in as much pain as you suspect they might be. And heresy of heresy, which I've said in front of kind of like some of the pain tool gurus, is pain tools are not the only answer. They're a way of assessing one thing, but not everything. Okay, so meet Lily, the child that I mentioned at the beginning. She's a little girl that doesn't really exist apart from in my head, and I'll share how I got her out of my head and into the presentation. So Lily, this imaginary child, is standing in for all of the other children that I've nursed or worked with who have complex healthcare needs and are profoundly cognitively impaired beyond the point where things like Makaton or augmentative communication strategies can work. So they are potentially the most vulnerable children that you can have. Set against the old belief that they wouldn't experience pain, they wouldn't remember it, they wouldn't be able to process it as being difficult. They were largely ignored for quite a long time. The thing is, their pain burden is high. It gets higher as they get older, as more things happen. And the episodes that they have of pain are often persistent, frequent, and significant. The strategies that we have for assessment and treatment are not always adequate. And clinical uncertainty for both people prescribing and people administering medication is often high. We often don't quite know what to do with these children. They sometimes present in emergency departments, perhaps seizing, and the mum is really worried about the hip pain that she thinks the child has got, but we always focus on the seizures because that's the thing that's the most terrifying, and that's something that perhaps happens a lot for that child. The amount of pain research is still small. It's slow moving, even when, as with anything, it's quite difficult to get evidence actually into practice. And the tools that we've got for typically developing children don't always work for this group. And the tools that we have got are not always well liked by people in practice. So although we've got things like FLAC, NCC, PC and PPP, people are less familiar with them than they are with kind of like acute pain and other tools. And if you want to support healthcare professionals to become even more brilliant than they already are, we need resources to support them. Which is why I'm choosing to talk about this a bit tonight, because advocacy, education and spreading the word is kind of like part of the thing that makes my heart beat a little bit faster. And I wanted to do something. I'd written lots of papers, I'd written books. Joan Simons, who wrote one of the books with me, is in the audience. She's travelled from a long way south to be here tonight, and I'm delighted for that. But there's only so much that papers can do. It can make your managers happy. It certainly makes people that are involved in the ref return at the universities happy. It doesn't make necessarily a huge difference to children quickly enough. So we decided that what we would do was take the evidence that we'd got, some of the evidence that I'd been involved in, some of the stories that parents and siblings had told me, and then we started to create a script, because on part of a long way of a journey, we'd done an immersive soundscape, we'd done amazing, brilliant things with people, but I wanted something that was going to be portable, transportable and useful in teaching sessions and things like that. So we built a script from excerpts and quotations from parents and from professionals and from siblings. I worked with Rob, who's a writer, a professional writer. I can write quite well, but I can't write like Rob does, because he's got a very clever, original brain when it comes to writing. We shared our initial storylines with the parents, and we came up with probably the hardest one, 251 words of my entire writing career. The idea was that the story arc was going to be this distillation of messages. We wanted the parent to be the hero of the story, and we wanted it to demonstrate that parents are experts. We took the script to an animator who I'd worked with before, and he did these chalkboard drawings. He hand drew over 1,400 drawings to create the animation. It was an absolute labor of love for him. Once we'd created the animation, or the storyboard, we shared it with parents, and everything that I do goes back to the people that are the experts to make sure that it makes sense to them. So they asked us to change some things. We developed 2 information sheets, the resources here, and probably the thing that I'm singly most proud of in terms of the pain work that I've done is this movie animation, which will start.
This is Lily. She's wonderful and beautiful and
And that was, I think it's wonderful that. That was one of the mums who I work with who did the voiceover. We've been trying to work out whether or not we get some celebrity, but we decided we'd have a real person instead. And she sort of is fantastic. I'm going to wrap up very quickly because wishes for the future. End child poverty. Basically, things would be a whole lot better for children if they weren't poor, if they weren't growing up in adverse circumstances, if they had the sorts of things they need. We need to protect the well-being of children, and that's protect them from us in our enthusiasm to sort of cure, intervene, or whatever. We need to make sure that there's proper services for children to have, and that's getting increasingly difficult. We need to be child and or family centred in the way that we work and whatever's appropriate. I'm quite involved with trauma-informed care. We need to do care that doesn't add to people's trauma, children and families. And we need to make sure that children's rights are fully embedded. Or none of these things are kind of like rocket science, but they're sort of things. Wishes for children's nursing. I want children's nursing to grow to meet the needs of children and families. And that means kind of like the guys here who are doing loads of teaching the people out in practice, people that are writing policies, all of those people need to be thinking about how we can make things better for children. I want pre-registration routes into children's nursing absolutely protected. I know there's plenty of arguments of why they shouldn't be. I'm an advocate for keeping it. I wouldn't have been a nurse if I couldn't have trained right at the beginning. Stronger voice for children's nurses, and that means us being more vocal. More research and more evidence, because that's kind of where my bag is at the moment, and more opportunities for the next generation of nurses in whatever setting they're working in, and absolutely stronger career pathways. And I'm going to hand over to the last slide to Rosa Parks. She said, if I can sit down for freedom, you can stand up for children. I think it's a pretty powerful quote to finish on. So thank you very much for listening.
Thank you, Bernie. That was absolutely captivating. The opportunity for anyone to ask just a couple of questions, I think. I'm looking to Gillian, who's keeping an eye on the time for us. Questions?
Where's the Prosecco? I'll be out there anyway, talking to you.
Okay.
Just something. Sure, was the hope that the child had was it's a monster. But I remember my practice, and when I was a student nurse, I had a child. She kept saying was it's a monster. I can't wait to get rid of it.
Yeah.
It's funny how we're so far apart across the whole nursery, and our children have the same thoughts.
Yeah.
And it's just bizarre how children think that way. And that's what she said. I have a monster inside of her.
Yeah. And some of that, I'm not saying that we can sort of like mediate pain by just saying, no, it's not, but finding out why they think it's a monster, or, you know, I'm not in the least bit pretending that I've got enough therapy, counselling knowledge, but sometimes you can just, what do you mean by that? Because otherwise you're, oh, it's a monster sort of thing. And it could be that they use language differently to us. We always need to not clarify and not question, but explore. So I think it's quite important. Language is tricky even with adults. Adults will use language like that to talk about things that are difficult or challenging. Yeah, but we're more linked together than we're separate as human beings.
Thanks for that question, Virgil. Anyone else got a burning question? Can I ask you, Bernie, you've had a very eclectic research pathway. We were talking about this a little bit earlier. What advice would you give to the starting out early career researcher who's following your path into children's research around pain, for example?
Do something you love. And I would say find a network, find mentors. There's a lot more around today than there ever was when I was bashing around as a kind of like a bean in a kind of like cocoa tin. most of the advances that I've made in my thinking have come from talking to people that know more about something than I do. And I think that's fine. I think it's quite hard to say I'm going to plan my research career in this particular area. I'd have loved to have been specialised in children's pain. If I'd done that, I wouldn't have met or done half of the things that I have done that have been absolutely brilliant. And things change. So something that was really important, you know, is perhaps really important today, becomes less important if you put all of your eggs in one basket. You're then slightly stuck. So I think have a dream, follow it as best you can, but be prepared to sort of like realize that it's not going to be a straight path. Everybody's path is kind of like snakes and ladders, with more snakes as a researcher. You know, you keep falling off a cliff. You know, the paper's been rejected. I was saying to Kendra this morning, we've just had a stage 2 complicated bid rejected because they didn't, and one of the things was they didn't really see the point of the qualitative component. And sort of like, we've gone back 20 years, you know, for those sorts of comments to be made, because it felt like it was really important, because you have to fight still to get qualitative research into trials. So you're really careful what you put in. You don't make it fluffy. You make it as quantitatively qualitative as you possibly can, which is one of those things where you slightly perjure yourself as a research, you know, as a qualitative researcher, to make it look as robust as you possibly can do for people that might not understand it.
It's an interesting game to play, isn't it?
It is, yeah.
One more.
Yeah.
I am
Yeah.
of
There's large amounts of research are done on populations that are not typically representative of most of the population that you would want to represent. And when you're doing qualitative research where you've got quite small samples, you can make quite relatively big claims about quite non-diverse groups or children that are the least vulnerable. I think it's really hard. I think people still struggle with that. The thing is to make connections with people that have got those connections with children, and that takes time. And maybe that's another kind of career advice, is actually make networks and be consistent with those people over time for sort of, I don't know, working with Bernardos who have access to children in crisis. What we all have a tendency to do is buddy up to the people that are going to help us do the next research project, and then move on once we've done it, and we go and buddy up with another bunch of people that will help us get access to children in a different setting. Working with children's centres, working through children's centres champions who are parents, who understand the lives of people and can actually introduce you. I don't think I'm that posh, but who am I kidding? You know, compared to the lives of some people, hugely privileged, you know, white, educated, a researcher. I mean, some of the research champions that I've worked with said, you know, you're not bad for a posh person, and you're from London. I'm going like, I know, I fail on so many counts. but there's that sort of thing. I can't ever be, you know, I'm great grandmother age now, sort of thing. I have my bus pass that I can sort of wave around, and we get our bus passes at 66 in England. So I'm definitely over the hill. So children now almost don't see me as a threat because I think I'm probably so old I'm about to keel over or something like that. Or I frighten them because, you know, their nana's not very well, and I look a bit like, you know, I'm saying they just sort of their great grandma. So there's all sorts of different things. But I think make really strong connections and commit to them. PhD students who volunteer and stick with that volunteering work for the whole of their PhD, rather than just going in for 2 months, showing up, grabbing the data and then running off. It's not a way to build connections with charities and parents and communities. And we need help from our universities to make some of those connections as well, and more money for involving parent groups and things.
Thanks very much for that. That's really sound advice. I'd just like to invite Professor Judy Williams, PVC, to do some closing remarks and a vote of thanks.
Thank you very much, Kenda. Good evening, everybody. I would like to extend a heartfelt thank you to Professor Bernie Carter for such an insightful and thought-provoking lecture. We're just as excited at the end as we were at the beginning, so you can breathe easy after that. And the only difference is that we now have stories to tell that maybe we didn't have before you started. You are such an eloquent storyteller to deliver and drive change. Share stories that are challenging, personal, and emotional. I was worried that I wouldn't be able to get up here and speak because some of those really touched me. But that all hold children at the heart of everything that you do. The power of the animation, having a parent voice that, tells the story and has helped shape our thinking tonight. And I know I will go away richer from having listened to you. You've certainly given us a lot to reflect on, and your wisdom of how to engage effectively with children and their parents and communities is something I know that our researchers here will hold and cherish. We are grateful for the wisdom you've shared today, the stories that help shape our perspectives, and the voices that shone through every story that you told. At Queen's University, and especially in the School of Nursing and Midwifery, we deeply value the contributions of our honorary professors and our honorary professors of practice. Their expertise and leadership enrich our teaching, our learning, our research, our students, our communities, and our professional engagement. And we are truly fortunate to have you as part of our community. Bernie, thank you so much. So once again, can we all thank Bernie for such a wonderful talk and for being an honorary professor of practice? We're going to hold you very close to our hearts. Thank you.